ahead and get started. Welcome, everybody. My name is Al Stammers, and I'll be co-moderating tonight with Jeff Chores. Jeff is from the Detroit area. I'm from Pennsylvania. We've got a wonderful presentation tonight from a dedicated, outstanding individual who you may know from a previous presentation that she made in this webinar series. This is our 34th webinar, so we're pleased to have everybody join us tonight. It's going to be a titillating topic. Just to remind individuals, please complete the post-web survey, which I'll show you in just a second. Stay logged on for 45 minutes. A CEU certificate will be emailed for 1.2 Category 1 credits, usually within a week's time. If you have any issues with not getting that certificate, both Jeff and my emails will be on the last slide. So we'll make sure that you have access to that. And also the recorded presentation will be available on YouTube. A very simple survey, which we really appreciate you filling out. It helps us plan for the future. As a reminder, please use the chat area or the Q&A. The chat and the Q&A and the ribbon at the bottom of your screen, that will give you an opportunity to write questions that Jeff and I will feed on to our presenter. And also, you're welcome to use the chat room as well if there's something else that you want to discuss. We'll have a 35-minute presentation followed by 20 minutes of Q&A. And so let's get into it right now. And it's my pleasure to go ahead and introduce our speaker tonight. It's Debra Weinrich. Debbie is a phenomenal individual. She spent 10 years as a maternal newborn service nurse. Brings that experience to her counseling as an attorney. Debbie is well known. She's had practices both in the general legal area as well as defending complex medical cases. She's responsible for all aspects of the legal consultation and trials that she's involved with. She works with a variety of healthcare practitioners, including perfusionists, neuromonitoring physicians, and advanced practice providers, and of course nurses as well. Debbie's practice includes an assortment of general litigation, and also including construction, premises liability, and other personal injury matters. She's been recognized by receiving in 2019 the Distinguished Advocate Award by the Superior Center for Child Advocates for her pro bono services. So we're happy to have Deb present tonight, and she's going to specifically be emphasizing on record keeping for perfusionists. So with that, Deb, please take control of the screen and begin the presentation.
All right, thanks, Al. Good afternoon or almost evening, everybody. As Al said, today we're going to talk about documentation in the perfusion setting. We are, sorry, I'm having, we practiced and my screen is not running. There we go. Got it. Anyway, the objectives today for this is going to be speed documentation. So I'm going to talk fast, hopefully not too fast. But the goal is really to identify some common problems that we see in litigation with documentation, to explain the impact, what happens when you document in a poor fashion, and identify ways that you can improve. So with that being said, the first thing I need to make you very aware of is that your clinical notes and your chart entries are extremely important. They are the basis of the lawsuit that gets filed. If a lawsuit gets filed, if there's a bad outcome, if you have a chart that's really good and explains and doesn't leave any holes and things were done right, most likely a lawsuit's not going to get filed. Conversely, if you leave big gaps and you're sloppy in your documentation, then plaintiff's lawyer is like, they're sloppy. It looks like they didn't know what they were doing. They didn't document they did this. They didn't document that they talked to this person. So we're going to bring a lawsuit. A significant amount of time is spent dissecting your chart entries. I mean, minutia, when they were entered, who entered them, how long it took to get in, whether you used a prefab or you were typing yourself. All all of that being said, I've never once seen a case that doesn't have documentation problems. And I know most of you are probably excellent providers. I guarantee you're not documenting perfectly. It's just not happening. So I'm hoping to give you a little bit of reminders. Some of these things you will have heard before, but I want to remind you because it is so important. Now, the thing that's happening in perfusion is you're going from fully paper to electronic, or you're not, you're still in paper, or you're somewhere in between where you're semi-integrated. You have some paper, some electronic. You have some that's using electronic equipment that's blowing things into your chart, into your Epic chart, or whichever system you're using. And there are issues that go with those. A lot of the issues we see are actually the same. Some are different, but those are the same. And the next few slides are just going to tag and highlight a couple, well, more than a couple of these issues. Typos and incorrect information. You can do it in both paper or electronic. I think that it's easier, quite frankly, to click on the wrong thing in an electronic chart than it is to actually handwrite an incorrect thing. So paper might be better in that instance. So you have to pay attention if you're clicking on check boxes and drop down boxes that you're clicking the right thing. You can't rush and just think you click. You have to see it blow in and go into your chart. Because if you put the wrong thing, they're going to say, well, you did this, you charted that you did this, and you're going to have to explain how you messed up. Late entries. Now, late entries aren't always bad. Sometimes they're absolutely necessary. And we were speaking before the webinar started tonight. And one of the issues is that absolutely 1,000%, I want you to focus on clinical care first. That is your main job. And if you're having an event, a problem, we were talking about an air embolism, right? If you have an air embolism, it's not about typing in the chart that you're having an air embolism. It's about figuring out what you guys are going to do, isolate it, aspirate it, and hopefully this person's not going to die, right? So let's not focus completely on your chart. Focus on the patient. That being said, I want you to, as soon as you can, contemporaneously put in the chart what happened and what you guys did to fix it. And I want it in your chart before you close that chart that day. I don't want you going back, if at all possible, 2 days later to start amending your chart. It looks very defensive and they'll try to use it against you. So take the time, even if there's a bad event, before you close out and file that chart, to write down what happened very objectively, and state what you did. Lack of documented communication. Hate this. It's critical and it happens a lot. Because there may not be a spot on your paper chart or even really in your electronic chart that tells you how to document this or where to document this, or you have to click out of a screen and go to another screen to do it. But if something is going on, I don't know, mean arterial pressure is dropping in the toilet, then you have to say to the anesthesiologist and to the surgeon, hey, our map's down, and what are we going to do about it? You're going to then take steps on your end. The anesthesia may take steps on their end, but the surgeon needs to be informed. Everybody needs to be informed, and you need to document that you told them and they acknowledged it, and the plan was this, and these are the steps that were taken. Document that you talk to people, because I'm telling you now, 2 years down the road, it's going to be, I have a slide on it. We're going to talk about it more. This changeable time or preset time on electronic medical records kills me. I would like you to use the most precise time frame that you can. I'm going to show you a few of these as examples later, but just keep that in mind. Subjective commentary. So if things are bad and things went bad, I don't want you writing subjective commentary, making judgments, or infighting in the charts. It doesn't help anybody. Keep it to yourself, out of the chart. It will come to bite you, whether you think you're right, wrong, or indifferent. Do not start fighting with each other. Objective data. I said this, the physician said no orders received, whatever it is. Not, the doctor was lazy and didn't give me any instruction or didn't care. Don't write that in your chart. Incomplete. It speaks for itself. If you don't chart your it wasn't done. Many of you have heard that. The plaintiff's lawyers use it against you. In reality, it's not true. That if you didn't document it, isn't done. Everybody is taught that or uses that as a training mechanism to make sure that you're charting. I honestly can work against that. I have an argument against that, but I want you to keep that mantra in mind, because two years down the road, if you didn't document it, you didn't document that you took steps to increase the map, then they're going to say you didn't do anything because nothing's documented. Vague is the same thing. This one is obvious, but more often than not, you'll see abnormal findings in the chart. Now, maybe they got blown into your chart and you didn't pick up on them. That's a problem. But maybe you did an abnormal finding and you didn't take any action. You didn't speak to anybody. You didn't alter anything that you were doing fluid or volume wise. And that's a problem. They're going to say, this number was bad. You knew it was bad. Your training and experience told you that you were supposed to do something and you didn't do anything. Pre-populating and copy and paste. Again, that's really what's only with electronic records, but I can tell you it's a nature of the beast. Electronic narratives with history and even the diagnoses that are all listed, sometimes they have errors or sometimes they're not up to date. So if you just assume that they're all correct and they get pre-populated into your document, that can be a problem. Alert issues and fatigue. We'll talk a little bit more about alert issues later. Now, some of the electronic medical record systems have something called sticky notes or post-it notes or that are kind of not in the record, but you can pull down and put like a little cheat sheet thing in there. Please don't use those for substantive information. If you need it in your chart, then it should be in your chart. If it doesn't need to be in your chart, it doesn't need to be on a sticky note. They will find it. We will have to turn it over. So you can't, just because it's hidden doesn't mean that it's safe. Because I can tell you right now, nothing you write about a case, no matter where you write it, is safe. There are very few exceptions, and I'm not even going to address them. Assume that every piece of paper or every electronic keystroke that you put in talking about a case, it is going to likely be discoverable, and they will blow it up in the courtroom and say, they knew this was a problem. Look what they wrote. They wrote this or that. They told their manager that they messed up. Nothing you write. It's not just about the chart. It's about everywhere that you write. Order sets. Order sets can be a problem if you guys are not confirming that the order set is applicable and that the surgeon is going to follow that order set. And maybe the doctor's not familiar with the full order set, or maybe this patient has a separate thing. So if you're dealing with order sets, you want to speak to the surgeon at the beginning of the case and talk about the plan and make sure that the order sets, to the extent they're available to you, are in fact correct in what the surgeon wants to use. Same thing with order entry and other workarounds. With electronic records, if it's hard, there's studies on it. You can read about them. Sometimes the electronic records are not really all that user-friendly. They're annoying. And users find ways to get around using the system the way the system was designed. That can be a really big problem. So try to use the system specifically. Now, again, if you can't get an order to go in and you need to put an order in order to get a drug because the drug's not available in the OR or something like that, and you're having to get on the phone with the pharmacy or whatever, yes, clinical care comes first, but you want to try to avoid that as much as possible. This one you've all heard every time when you were a student, you heard about this. Only use abbreviations that are approved. And you need to be familiar with the approved abbreviations. Gaps, this is another way of saying incomplete. These are gaps, especially when the records are printed out. One thing you should understand is you guys have the nice user-friendly software where you can click on tabs and pull up the screens. When lawyers get the printed copy, we don't have the software to access it. So we're getting PDFs. So when you look at the chart later in litigation, it won't look like it appears to you. So sometimes if you leave sections blank, those gaps become very apparent when the document's printed out. So make sure that you're filling out all the boxes you're supposed to fill out. I speed scrolled there. So here's a screenshot that somebody was nice enough to provide me, and I just wanted to show you certain things on it. And the first thing here is this 1300, 1400. So these are hour blocks, right? Well, what happens if you need to, this is obviously for ECMO. So what happens if you need to check it more than once an hour? Then, do you have the capability? Now, it looks as though this software may be able to check it, and you may be able to enter a different time. So that would be good. The other thing is that I mentioned this when they only have hour blocks. So say you did this one at 1300, right? 1 o'clock. Then you went to lunch and you had a bunch of other ECMO patients to deal with, and you don't really get back at 2 o'clock. You get back at like 2:55. Well, if you're supposed to check this ECMO, how it's going once an hour, that's really 2 hours. We're very close to 2 hours. They'll figure it out. They'll get an audit trail that likely will tell them that this was entered at whatever time and this wasn't here. And if something went bad in here, you're in big trouble because you didn't do your clinical work in a timely fashion, and they'll figure it out. So you have to listen to your institutions. So if the institutions say that you have to use this 1300 block, then you're going to have to use 1300 block. I would much prefer that you would put in the specific time that you did it. And I would like you to be compliant with your guidelines that say you have to check it once an hour, not every 1 hour and 45 minutes. Now, again, this one happens to have some blanks. I can tell you that they didn't give this to me with blanks. I put them, I added them. But if you, for whatever reason, if these are not blown in, because again, I don't know what system you're working on, and I'm not sure what can be blown in and what cannot be blown in. But if these are not blown in and you just miss these, well, if the stats become critical, or if they become part of the theory, then they're going to say, oh, well, you have no way of proving that this stat wasn't this number or whatever. And they, it just happens to be that one because it was easy enough. But gaps are a problem. This is an example of blown in information. So I guarantee that however this got in here, in this particular institution's form, that it was blown in. I just know. But maybe many of you just assume that all that information is correct and you kind of glance at it, but you don't really pay attention to it. Please recognize that this is blown into a very specific perfusion document. It's not anybody else's documentation. It's the perfusionist documentation. And the institution has decided that this information is important, and it's important to you because they've included it in your sheet. So if you don't pay attention to what is written on this sheet, and if there's some anomaly that you miss, or some weird thing, maybe, they have maybe it's not other disorders of electrolyte and fluid balance, though that in all honesty could be a problem in and of itself, but maybe it's the blood clotting problem, or I don't know, they've had heparin resistance in the past, right? If you miss it, that's a key factor. And then if they go on to have a problem and you didn't say it, they'll be like, you didn't take any steps to address that in your plan. So pay attention to what gets blown in. Another example, this is just further down from that same sheet. Again, you're getting a whole bunch of stuff blown in. And it was taken, who knows whether it was taken the day before, 2 days before, or however, who knows? And these all may be fine. But what happens, for instance, and again, I don't do perfusion, so I don't know what's the most critical number to you, but let's just say this INR number is like 12, right? That's bad. So you don't pay attention to it. The doctor, you guys never discuss it. Nobody's paying attention. But if it has an impact on the plan, and if you're not meeting the standard of care for a patient that has an INR that's out of whack, then they're going to say, well, you should have known because it was blown in your chart. This is another example of this standardized flow sheet. So I can tell you, as Al said in the beginning, I was a labor and delivery nurse once a long time ago. And we had flow sheets just like this. So we had to do it every 15 minutes or even more sometimes. But these are half an hour blocks. Now, I don't know about you, but I read this as 1400 is here, and this is 1430, and this is 1430, and then this would be what? I'm not even sure, because 1430, well, 1415 to 1430, 1430 to 1445, 1445 to 1500. So it's right. But I can tell you in my labor and delivery days, there were other nurses, very competent, very skilled nurses who were using the blocks differently than me. So if these are not being blown in automatically, I can tell you that these happen to be blown in. But if they're not blown in automatically, you want to make sure that you're using the correct block. Now, this is, again, a pressure. These don't tell you what time these were taken, right? They only tell you they were taken in I'm assuming that we're following this up, that this was taken between 1415 and 1430. And this is taken sometime in the interim. Again, I don't know if these are blown in. I would much prefer the exact times. There's a big difference between the first 15 minutes and at the end of 15-minute block, when somebody's pressure is down. Say somebody, pressure down, and they come and say, you guys made my loved one brain damage because you didn't keep the pressures up and their neurologic system was critically impaired because of you did sloppy perfusion. Well, I'd like to know when these, how long the maps were down. These aren't, down, but if the numbers are down, I'd like to know precisely if it's an option. And we're talking about communication. And I know most of your charts don't have a heck of a lot of space for communication. And these newer charts, the electronic charts are not much better than the paper charts. I'm just thinking that in this particular case, that this at an event, and they said they, did this with the Impella. So this would be presumably a place that you may be able to type in a narrative. So look for those places and notice very nicely the very specific times. I don't know if those were hand typed or if they were automatically populated by the machine. But automatically populated by the machine when you add a note is helpful. This is highlighted here because it appears as though this is kind of the MAR of the perfusion sheet, and the very specific times were listed when these were put in, and they do correlate to these. So this is just a second place where you can find that data, which must be built in for you guys' ease of use. So sometimes, even though up here you really can't tell what time, there really is another place in the chart that will give you that specific. So you just need to know how the times are put in. Again, another example of very specific times versus others. Now, I don't know what device means, to be honest. You guys probably do. I know what arterial is. I don't know what device means. But again, very specific times are very helpful, especially for blood gas as a critical information. Now, this one I highlighted because I'm not sure if they use pre-populated choices or if they type these, but they seem a little bit odd to me. So for instance, he talks about these plots, and one says medium and one says small. Well, you should know what your institution's guidelines are to define that. But there must be a key, and if there's not a key, then you have to use a better description of that. Or have an understanding or being under a guideline that you're being consistent with. These alarm limits, are they automatically put in, or were those alarms something that you confirmed, or are they consistent with guidelines? These other things that you're checking off at the beginning, it says performed, 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 performed. But then down here, they don't say perform, they say yes. So this is a secured yes. That would be performed also. So I'm not really sure why these drop downs have different yeses and performed, but be careful about them. There's also blanks here. You want to make sure that you have who was in the room at the time and who was involved in that timeout. I'm not a huge fan of these checklists, either in paper or in written electronic form. I find that, you know, y'all get a little lazy sometimes, even the best of you, and you just go, yes, 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 yes. Don't just yes, 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 yes. Don't just click yes, yes, yes. Actually do your checks. Because when something gets bad, you can't undo and say, I didn't check that. Or, you know, it's important from a clinical standpoint as well as a documentation standpoint. This is just another example of a checklist. It's blurry, I know, but this happens to be an Epic checklist. These are the same thing. You just click, 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 click. Please pay attention. Don't get robotic and just say, oh, I know I do all these things every time. I want you to check them. I want you to read them. Don't get sloppy. It'll cost you later. So again, alarms. Do you have any? Are they preset? Do you have any input into them? Are they part of a plan? Preset numbers that, I don't know, the doctors described about how low he's comfortable with the map down. I'm not sure. These are all different. These are different institutions, different equipment. But if you have, you know, alarms that are going off and they're repeatedly going off, are you charting those? Are you not charting those? Are those marked as something that you're charting? Is that something the guidelines in your institution say you should chart? Do you think that just because you don't chart them, that we're not going to be able to figure out that you had alarms? Well, depending on the equipment, and now it's getting more and more sophisticated, don't assume that we're not going to be able to figure out their alarms. And if you're just like alarm shutting off, we've all read about nurses on the units and so forth, just hearing alarms and just shutting them off and just shutting them off because everything's alarming. The IVs are alarming, this is alarming, that's alarming, and everybody's ignoring the alarms. Please don't ignore your alarms. If your alarms are going off frequently, there's a problem. There's something wrong. I know you don't, you know, it may be commonplace for you guys or you understand why it's happening, but don't just assume. Make sure you pay attention and document according to your institution's guidelines. Now this, again, communication has a tendency to be a horrible thing because they don't really give you space to talk about it. There's not a lot. There may be just a surgeon told or an acknowledged, right? There may be that on a checklist. But that may not be enough. It helps, but especially if there are issues, you know, I have another slide about it, but I'll tell you now again. 2 years down the road, 2 years after you've had how many hundreds and thousands of cases in between, you're not going to remember what happened. And it's going to be problematic. You can save yourself from a lawsuit or from getting an adverse verdict against you if you documented, I told this, I did this. It's very important. Verbal orders, again, you have to document them. Are you allowed to take them? Does your institution allow you to take them, or does it have to go through anesthesia? You know, make sure they're documented according to plan. These odd values, that goes with that abnormal issue, and then you don't do anything about it. You kill me. I'm telling you, you kill me. I get there and I'm like, okay, well, what'd you do? And well, I usually would have done this. I don't want to hear it. I usually would have done this. Yeah, I'll work with what you give me. But what I need you to do is acknowledge it and say, I told the surgeon, we did this, anesthesia gave him this drug, I increased the flow, I don't know, you know, whatever you do with the reservoir and the oxygenator, whatever it is you're doing, then acknowledge it, do it. Same thing with troubleshooting. You know, if you have, again, I don't do this, so forgive the wrong words that come out of my mouth in a situation, but you have low flow What are you doing to troubleshoot? Is it the cannula? You mentioned it to the surgeon. Is that like angled wrong? Or is there kink? Or is, your clamp's only halfway across and you're getting flow that shouldn't be flowing? What are you doing to figure out why you're getting these values? And you don't have all day to fix them, right? You are the person's life support. You are them. You are in charge of, you have their body, it's all you. So you have to do it timely and recognize. Same thing with complications. Need to communicate. And we already talked about the plan. Make sure that you understand the plan. Make sure that you're familiar with the plan. Make sure you agree with the plan. If you disagree with something, say you have a new surgeon and I don't know, they just come in from across country or they came from across, an ocean somewhere in either direction, but they do something really strange as far as and you've never seen it. So if you're not comfortable, then I want you to discuss the plan. And if you're really not comfortable, then you need to pick up your phone and speak to your manager, speak to somebody, and do not start doing a procedure that with a plan that you don't agree with. You have to make sure that you've discussed it and understand the plan, and you guys are both on the same team and the same page. And I've said this. So 2 years down the road, you're in a deposition room and you're sitting there and they're asking you everything you remember. And you're going to go, I don't remember anything. Unless it's an air embolism and it's your first one and you were traumatized. You might remember some. I get it. But most of the time, you're going to be like, don't remember this patient. No, that happens all the time. I don't remember. I can't say. What I normally would say is we always discuss it. Everybody in the room discusses it. When we have an issue like this, there's lots of things happening and we discussed that and we talked about it. But no, I didn't document it anyway. So you just want me to take your word, sir, ma'am. So you just want me to take your word that you told everybody this. I can tell you that the surgeons aren't going to remember anything either. And it's not because they want to throw you under the bus. Maybe sometimes they will. And maybe you want to throw the surgeon under the bus. The goal is not to throw anybody under the bus. But what happens is that they'll say, I don't remember what I was told. I don't remember. I can't say. Wasn't documented. So the only way for you to be able to speak to and testify about what you did is to make a record and make a tight, clean record. You're doing the work. You guys are doing the work. And it's very detailed and I'm sure you're really good at it. But if you don't document it to demonstrate what you did, and there's a bad outcome, there's a plaintiff's lawyer who's out there ready to make a case. And they'll make a case and it'll take several years. I mean, I do a lot of work in Philadelphia. I'm sitting in Philadelphia now. Philadelphia, it's 2-year track for a medical malpractice case. And you usually get an extension, so it might be 3 years. So it's going to take that much of your life. It'll be hanging over your head. So let's just document really well. Avoid it altogether. Now, incident report, variance report, whatever your institution calls them. Post-event documentation. As I said in the beginning, this isn't just about your clinical documentation. It is about everything you document about a case. Because you think it's all safe, right? You're texting your boss, you're emailing the institution you work for, the manager's emailing you and asking questions. And you're like, I'm just going to tell them what happened, whatever. I'm just going to keep communicating and just answering questions. No, halt. Only objective facts. No, don't be subjective. No, because your emotion, I don't want you to put emotion into those communications. I don't want you to speak to causation. It is somebody else's job, a peer review, an M&M meeting. Somebody else's responsibility to find out what happened. They may talk to you, they may have a meeting with you or a phone conversation, or you may be part of a peer review meeting. Those are all fine. All those verbal communications are great, open, so that everybody can learn and get better. That's all great. The problem is that there are very few protections for what you said. And many of you don't realize that. And then all those emails come out and you guys are like freewheeling about things that aren't true, shouldn't have been said, And then we have to backtrack and try to get out of them, and it's hard. So if somebody from your institution, if if you work for an institution, you're employed, or if you're a contractor, a contracted vendor providing services in an institution, but your employer's different. If somebody from that institution contacts you about a case, I want you to pick up the phone and call legal and just say there's been this issue and they're asking me to talk about this. They want me to attend a meeting. Let legal know, because some things with legal are protected and you can get a little more safety in those. It's not that we're hiding anything. It's not that I'm not telling you guys to tell the truth. That's not it at all. I'm just telling you to be careful and circumspect when you're describing things. So I'm just about at the end. I have 3 minutes according to my clock. Again, demonstrate how good you are at your job, both with clinical actions and document. They're hand in hand and they're both really important. Review your guidelines. The guidelines are written by your institutions. They spent time writing them. There's a reason they're there. And you may have not read them for 10 years because you've been doing this for 10 years or more and you think you know everything. I guarantee you don't know everything. And I guarantee you're probably not doing everything according to the guidelines because you just got in the habit and your practice is your practice. And maybe you've been lucky and you haven't had to become involved in litigation or have a problem. But it is always good practice to review your guidelines and you follow them. You may find, oh, I didn't realize that, or they changed that and I didn't realize they changed it or it didn't click. Review your guidelines. I would say at least once a year for experienced people. And honestly, if you're less experienced, review them more than once a year, twice a year. Really pay attention because if you follow the guidelines from the beginning, they are going to help you get into really good practice. And good practice, including documentation, is important. And as I said at the outset, you honestly can cross my heart, hope to die, stick a needle in my eye. I'm telling you, you can be the difference between a lawsuit being brought and one not being brought with the same exact facts. What the care that was rendered and the outcome is the same. One case documentation is great and explains everything you did. So you're good. You're in a good place. And then the other is not. They're going to bring the lawsuit. Now, I can't promise you that even if you do really great documentation, that there wasn't a problem and you still won't be in a lawsuit. But I can tell you, you can significantly reduce the chances of that actually happening. So I know we're going to have questions and we're going to switch off my screen. I'm happy to answer whatever I can in the short time frame we have. Again, this was speed documentation. There's lots of minutia, but I'm happy to try to answer some of your questions. I'm going to stop sharing.
Deb, I just want to thank you for your wisdom and a great presentation and all your insight. I want to jump right into the questions and ask for some clarification on your position on checklists. One of the questions here is, if you don't like checklists, what would you suggest as an alternative for complicated tasks that typically utilize them?
There really isn't an alternative. I just don't like them because they end up, people get lazy about them, but they're necessary and they're helpful. If you actually look and do the things on the checklist and check correctly, then they're perfect. My problem with the checklist is really the laziness and people get used to saying it. Oh yeah, I checked the O2 tank. I did that. I did all this. That's my problem with them.
So Deb, some centers are using checklists, but they're also doing something called read verify, where the primary perfusionist will go through the checklist and then someone comes back and goes through it with them afterwards again. Is that an acceptable approach?
Yeah, that's great. Two people checking the same thing and making sure, always, two pairs of eyes are always better than one. Safety in numbers.
Okay, thanks, Deb. We have two questions on electronic charting. The first one is related to how powerful an electronic checklist would be, an electronic record, not necessarily a checklist, an electronic perfusion record would be compared to a handwritten. does it work both ways, or is the electronic record always the preferred method for documentation?
I will not say that one is absolutely better than the other. You can do phenomenal charting on paper. I'm not saying that paper's bad. I'm not saying that electronic is not going to get rid of paper over the time. I think it's going to happen. But I just think people need to make sure and be very aware of the problematic areas, such as the blow-in information, such as just clicking the wrong drop-down box, and solely relying on just checklists and not putting any narrative, especially about particular communication and events.
Thank you. Along the same lines, electronic records.
Al, I'm having a little bit of a hard time hearing you.
Sorry. In electronic records, there are occasions where the information in the electronic record may not be correct or accurate for what was going on at that particular time. Is there some way that the comment should be made to explain what that is? And if so, is brevity the preferred addition to add in that comment line?
If there's something wrong in the chart and you know it's wrong, yes, you have to address it. You don't want to leave it and not address it. So I would say you would have to make a comment. Again, I don't know specifically whether, again, you have a lot of times you have great information now, and I don't know whether it's the Viper system or whatever it is, but a lot of things are blown into the chart and you have a lot more data than you used to have, and we can access more data. But if something is in the chart that was blown in incorrectly, then I would say that you should comment on it.
Thank you.
Deb, just really quickly in lines of that, define blown in for people.
So blown in information would be, for instance, taking information from your perfusion system and it's integrated with Epic so that it can take information from your perfusion system and put it into the Epic chart. Or it's taking information from the Epic chart, labs and so forth, and blowing it into your perfusion record. Those are two examples.
Thank you. Is it wise, one of the questions here is it wise to keep a personal journal with comments on each case we do? Comments on what went well and maybe what may not have.
I would not write anything down. I would not keep personal records of the case. Put what you need to put in the chart. If you believe something went wrong and that it's enough that you're worried that you're going to have to answer for it later or discuss it with somebody later, then pick up the phone and call legal, because that conversation and the communication and that you have a much better chance. Again, the laws are different with everybody, but you can raise it with legal and legal can speak to quality, or you can have an M&M or a peer review meeting. But I would not sit at home with a notebook about your cases, because they're going to get to that too. And by the way, they're going to get to your cell phone. If they really push, they will ask for your text for the time during and up to days after. They'll get your texts. So you don't want to have a book that you have to answer for.
Deb, on your last slide, you talked about guidelines. Professional societies, specifically AMSEC, the American Society of Extraordinary Technology, for decades has published guidelines. This past year, the standards and guidelines for AMSEC were updated, and they've been endorsed by multiple societies, perfusion, surgeon, and anesthesia. The question that one of our attendees has is regards to their legal power, in the sense that these guidelines are published, the standards and guidelines, a standard is a must, a guideline is a shall. And how are they interpreted in court? Are either plaintiff or defense counsel able to use these as references? And if so, how valid are they?
So the answer is almost ubiquitously, yes, they will be used or referenced. They will be used by an expert in Pennsylvania, and each state is different, and each country I'm sure is different as well. But for instance, in Pennsylvania, New Jersey, the East Coast states, what we do is we have an expert. We have expert reports and they write, this is what the standard of care is, and this is how they breach the standard of care. Boom, boom, boom. And if they want, they can use those guidelines. And society guidelines, a lot of times they are just guidelines, and they may even say on them, these are not interpreted to mean the standard of care. I've had those. But if they're accepted, if they are reasonably relied on or authoritative in the community, then yes, they are going to be used, and they are going to use them against you and for you, depending on which way they go. We use them to say, look, we did exactly what they said. The goal is that you want to use evidence-based medicine, pure and simple. If you're practicing evidence-based medicine, then you are usually in the clear. The only way you can practice evidence-based medicine is getting and reading the studies and seeing the guidelines. Those guidelines are usually developed based on studies and a consensus. So yes, they can be used both for and against you to help establish the standard of care by an expert.
If I could follow up with a question for Deb along that same line. Deb, in the operating room, there's a number of individuals, a surgeon, anesthesiologist, perfusionist. What happens if the perfusionist has these guidelines and he or she knows the best available evidence, but then is instructed by the surgeon to vary from that other than a short period of time? An example could be flow rate, either on ECMO or bypass, where your flow rate is established in some range and the surgeon tells you to vary from that, and not just momentarily, but for a substantial time that you may feel would be outside of what a good practice would be or best available evidence. Any suggestions there, what to do?
Yeah, it's a hairy topic, and there's a little bit of it depends on that. You definitely need to have a conversation and say, it's my understanding that we really shouldn't drop the flow rate or increase the flow rate that high. Did I hear you correctly? Are you sure that that's the number you're looking for? And if they say yes, unless you think it's like a huge variance and you need to get on the phone with somebody and be like, he wants me to do this. Now, a lot of times you can't do that while you're there, while you're sitting there. Because it's critical time frame. So you wouldn't necessarily get on the phone right away. But if it's not critical time frame and you really feel you need to speak to your manager, then pick up the phone. If things can halt. If they can't halt, then you're going to have to do what the doctor says. The surgeon is in charge of that surgery. Even though he or she is not a perfusionist, I would document it. Discussion, doctor asked for this flow rate, discussion had, doctor very clear, and in order to give that, use this flow rate, and you put it in the chart. You don't have to say that you're arguing with it, that you don't think it's evidence-based medicine and you don't think it's right. You just have to say, doctor asked for a flow rate of X, discussion had, and ordered to use flow rate X. So you're having that discussion and you've documented in the briefest brevity, brief terms, that's what it is. And then you would document maybe on an incident report later, or if your manager wants you to, you could say this flow rate was outside your belief standard of care. But you wouldn't write that in the document. You'd say, I would talk to your manager before you fill out that form. Does that make sense? Hope so.
Thank you.
Paul de Gregorio wants to know, who determines what the standard of care is? From an attorney's perspective, how do you reference a standard of care?
So again, most courts are the same. I'm not familiar with international courts, so I can't speak to those. But most states are generally, they have some variance. But in Pennsylvania, New Jersey, and even in Delaware, we are required to get an expert. We get more than one usually. We're getting damages experts, standard of care experts, all kinds. But from a standard of care perspective, plaintiffs will have a doctor. They will say what they believe was the standard of care and how you breached it. They will say, I've been doing this for X time, and based on this, they should have done X and Y, and that's below the standard of care. And we will then have an expert that normally, hopefully, says, no, you're wrong. they met the standard of care. The standard of care is this, and this is completely reasonable within the standard of care. Now, how does the expert determine what the standard of care is? They use their expertise, their practice, and they may use guidelines. Now, I cannot use medical literature in the courtroom at trial and say, this says that this is what it is, unless one of the witnesses, whichever expert or clinician, says that that material is authoritative or usually relied upon by the clinicians in that community. So I can't just pull up any random article and definitely get it into the trial. But it's the standard of care is established by a qualified, quote unquote, expert. And we get to voir dire them, which is voir dire means that we go through their qualifications. We try to punch holes in their qualifications, and they try to punch holes in our person's qualifications and to speak to whether they really are experts or not. But they usually can get an expert to say, well, pretty much whatever their theory is.
Thanks, Deb. Manel asked a quick question. He wants to know, for incorrect entries in electronic records that are uneditable, is it enough to just add in the comment section as an entry error and countersign it, or does more need to be entered to explain it?
Well, I think it's going to depend, in all honesty, on what's wrong. Is what's wrong critically important to what you're doing? Is it because the electronic system is like gone funky and it's giving, the rates are all off by 10 points? Or is it just one isolated incident that came from history? If it's an isolated entry that has something to do with the patient's history, then you can say at the beginning of the case, you say, I discussed with the surgeon and was informed that this entry was incorrect. Boom, enough said, just a comment. But again, I don't know, without knowing specifically what the incorrect entry is, how crucial it is, how much you would have to document. But I would think it would be a very basic note. Now, if your electronic equipment is malfunctioning and all the data that's getting blown in or the readings, the readings are all messed up, then you have to get a new machine in there. And you have to document what you did and that you figured it out, or how the workaround, like you got IT or you got another another setup. Depending on what it is, will dictate how much you have to document. The more critical it is, the more documentation.
Harvey Ellis, a very experienced perfusionist, asked this question. He's making a comment as well as a question. He says that he knows colleagues who are running a bypass case who don't document during the case because they feel the anesthesia, I assume it's an electronic anesthesia record or automated data collection, is capturing that information, so they feel they don't have to document. What are your thoughts on that comment?
My thought is I really don't want to defend them. I really don't want to have to defend them. Are you seeing what the values are? I mean, what are you there for? You're there, you're a professional. You have responsibility to watch and deal with and adjust the flow rates, the everything that's going on there, adding meds, protamine or whatever, heparin, whatever you're doing. And to simply just say that the anesthesiologist is writing down the right stuff, or that he's capturing all the data that you needed, I don't feel that I do not feel that is adequate. Now, I'm not familiar with the anesthesiologist record, and I'm not familiar with whoever this individual is employed by, that they have guidelines that say I don't want you documenting. If they have guidelines that say that, then we deal with those guidelines, because maybe that documentation is done. But it sounds dangerous to me.
And I have a quick question in regards to outsource and in-house perfusion providers. I think most in-house individuals establish policies and procedures. I'm sure it's a standard to have these policies and procedures, but where they are maintained, most of now, whether you're an in-house or an outsource, everything is electronic now. But if you're an outsourced provider and you have the electronic documentation on an internet site, would that suffice, or do we have to have that documentation in the individual hospital where the outsourced provider is providing services.
Well, there's two different sets of guidelines you're dealing with if you're outsourced. So if you're outsourced, you have your employer, the vendor, they have their own guidelines, but probably everybody's available on the intranet. Probably all of you have access to your intranets remotely. And the hospital, most of the time, the vendor contracts say that you'll comply with the hospital or surgery center, whatever the institution is where you're providing services, and that you should have access to those policies that work for you, that are applied to you. Do you have to have a copy? No, but you would hopefully have access through the institution's intranet so that you can comply with their policies as well. If you find there's a conflict between the two policies, that's something you have to bring up with your manager, and it has to be addressed with your manager, who then takes it up to whomever they need to take up in the chain of command. That's another thing we didn't talk about. Most of the time, if you have an issue, we kind of referenced it, but if there's an issue and there's a problem, here's an outlandish, right, example, but I can tell you I have had a case of it, and I had in my own clinical practice. If something's going on with the doctor, I don't know, the doctor just seems off, medicated, a slurred speech, droopy face, or just garbled speaking. Something appears to be either medically or, I don't know, chemically off with the surgeon. That's something that you can't be a potted plant about. If you notice that, you have to take action. You have a patient advocacy role to your patient. You have a patient relationship, provider-patient relationship, and you need to pick up the phone and get up that chain of command and make sure that gets addressed, and at least you took the step. Because, like I said, I had it in my own practice. I had to bring an OB down to the ER, and then I had to go visit him in the ICU, and he literally had a TIA and or a stroke, whatever. So that's something where is a weird example. But if there's something that puts a patient at risk, then and there's a huge dispute, or there's something that's really off, then you need to pick up the phone and get the chain of, work up the chain of command.
Deb, in regards to chain of command, Paul has a question. Is captain of the ship mentality still used for putting the surgeon or the MD in total charge?
Yes, the captain of the ship still exists, but they will work to find you. I mean, if you have a big battle, or if you have a battle or you didn't stand up, or you didn't acknowledge that it was wrong, or you didn't take any steps to avoid it, then it's great. But if the captain of the ship's not working, or if the captain of the ship is, I don't know, Pirates of the Caribbean, Jack Sprat, or whatever his name is, then you have a problem. So you have an obligation to step in to protect your patient, because they will say the questions. I can tell you the questions go like this: when you started perfusion that day on my client, you will agree with me, won't you, that you had a patient-provider relationship? Yeah. And as part of your patient and provider relationship, you had a duty to advocate for that patient, correct? Yes. And when that doctor wanted to cut it's weird, it's not fully, but when the doctor decided he wanted to cut the patient's toe off and you didn't do anything to stop it, you failed in your responsibility as a patient advocate. Now, that's a really bizarre example, but they use that for the same things. So if there's something really off, I don't know, cannula drops on the floor, and then they pick it up and then put it in the guy's heart, right? You can't let that happen. The circulating nurse will also have a problem there, but none of you all have to step in.
So even mid case, we don't wait till the end. We step in immediately.
If there is something that puts that patient at risk, and a very high probability of risk, yeah, if you don't stop and do anything, then you're a potted plant and you've dropped the ball. No, luckily it doesn't happen too often. It doesn't.
Great. Well, this is wonderful. We're at the top of the hour here. There were several other comments that it seems like everybody is leaning, or the people who are commenting are leaning towards electronic charting as being preferred over written, but that's just a comment. Deb, I want to thank you very much. Before we conclude, next month we are going to meet on October 25th. If you were fortunate enough to hear Mark Caruse's presentation last month on the first perfusion case. This is going to supplement it, but it's not going to be redundant to what Mark had gone over. This was going to be more looking at the history over the last 70 years of cardiopulmonary bypass, with input from two phenomenal individuals, Kelly Hedlund and Gary Grist, most knowledgeable people with Mark that I know on the history. But anyway, we're going to be presenting this a month from now. With that, I want to thank Debbie for this wonderful presentation. It's always stimulating, and really we can visit this a number of times again, and we'll invite Debbie back to present on this in future webinars. Her email is up on the screen right now if you want to reach out to her directly. Her background in healthcare is absolutely phenomenal, both in pediatrics and her experience in adults. If there's any issues with anything regarding these logistics, this presentation will be on YouTube. If you need to get a hold of Jeff or myself, there are our emails as well. So with that, I want to thank all the attendees for spending this wonderful hour with us. Deb, again, a wonderful presentation, definitely stimulating. And Jeff, for your co-moderation, and Maggie Ring, who puts all these webinars together. So on behalf of Jeff and Deb, I wish you all a pleasant evening, and we'll see you back here in October.
Thank you, everybody.
Thank you. Good night, everybody.